Good afternoon. I know we pretty much covered most of the abuse, aggression, and violence. I just want to go back and record this lecture for you. And if you have any question after you listen to the recording and then the lecture that we had on last week, please feel free to reach out to me. So again, we're going to be talking about abuse, and we kind of hit on that. We talked about different types of the abuse last week, where it's physiological, psychological, or it could be emotional, economic, or sexual. We kind of talked about some of the physical abuse of cases that you may come in contact with. And as we talk about physical abuse, it could be things like kicking, pushing, strangling, biting, to control others, of how to behave and how we should think they should behave rather. And also potential signs could be ripping of torn clothing, broken eyewear, disheveled hair and clothing, and also could be some body bruising, lacerations for the most part, burn marks. You see a lot of burn marks, particularly in babies, on the, their pampers out on the buttocks or whatever. Also fractured bones. You may see that as well as some form of physical abuse, and puncture wounds and wound in various states of healing. And remember I told you last week on if when you're doing your assessment, if a client has had some body injuries like tearing the skin or laceration, we definitely want to assess this to determine whether or not they've had tetanus toxoid the last time they had one. Emotional abuse, again, just as bad. We see a lot of that as well. This is basically the person who's responsible, abusing others may threat, may insult, or they may intimidate others to just basically to have control over that individual. So those individuals who have experienced abuse at a higher risk for developing substance abuse. So they are being abused, so they have a tendency to use substances. They may become depressed, may be anxious. They also may have eating disorders, maybe have borderline personality disorders, and of course, we talk about PTSD as well. So emotional abuse may be a little bit harder to recognize as a nurse or anyone because there's no physical evidence. So potential signs could be change in the client's behavior, such as social withdrawal or non-responsive communication. Low self-esteem also, and we talked about anxiety. It could also be provoked by presence of certain people, and claiming of enduring verbal or mental mistreatment. So again, emotional abuse just as bad as physical abuse. And we talked about sexual abuse, and this is basically any forced, inappropriate, or unwanted sexual contact is considered sexual abuse. And we talked last week saying that sexual abuse cases, they depending on the age of an individual or their mental status, those clients that are mentally challenged, we're mandatory reporters. They may present um, for care, and basically they usually come in like an ED outpatient setting for care, like emergency department. Um, Usually there are different like assessment tools that you can use, a lot of like the body art assessment too, where you can kind of draw to show whether there are signs of physical abuse. But actually, sexual abuse includes photographs also that are sexually explicit, uh, indecent exposure, unwanted touching, rape, forcing individuals to engage in sexual act or coerce uh, someone to become nude. So again, sexual abuse come in all forms. Digital online resources have simplified the grooming, luring, and exposure to children and adults to unwanted sexual explicit. So again, it can be online social interaction with someone could also be considered sexual abuse. We are mandatory reporters, as I said last week, of any form of neglect. Also, some potential signs that you may see in these clients could be things like certain change in the behavior, fear of other people, or fear of being in certain places, sexual explicit behavior or sexual sex play. They could be regress. Young adults usually sometimes they young people they usually regress. They may go back to bed wet, and if they wet the bed in the past, they may go back to it. This is a potential sign of sexual abuse. Developmentally inappropriate interest in human sexuality could also be a potential sign. Discomfortable, bruising, bleeding around the breast, anus area, genitalia areas. Uh, underclothing that is damaged or contains stains. So these are all potential signs. And then also unexplained or reoccurring STIs could be another sign of sexual abuse as well. So again, we some other signs could be neglect and abandonment, unattended, untreated health problems. These clients do not seek health care because they don't want anybody to see the bruises, things like that. They may be dehydrated, they may be malnourished, and then again, may have some pressure ulcers that are not treated, poor hygiene. Hazardous living condition includes improper electrical work, or no running water. This is all, and as I mentioned last week, you kind of see this in the elderly population. Those clients that are very, very vulnerable population of people, they don't have anything to eat. Somebody exploit them, take their check, so they can't pay their bills. Um, Dirty insect infestation, soil bedding, fecal urine smell, insufficient clothing, some other signs that you may see in those clients with poor living condition. Desertion of valuable individuals. Again, client claiming of being abandoned or mistreated. Again, those clients are withdrawn. Sometimes they may talk about it, and sometimes they may not talk about it. So again, we have to pay attention to any signs and symptoms. Then financial abuse. This is basically an example. This would be like stealing or forcing checks, promising to pay bills for a person, but keeping the money for themselves, falsifying wills, or the financial documents, you know. So again, unexplained withdrawals, transfers. So basically, financial abuse just as bad, and a lot of scammers will try to reach out to elderly population. They scam them. This is the same thing as abuse and neglect. So again, have to be very conscientious. We need to talk about it. Family members need to be involved in the care, particularly the elderly population, and then the vulnerable population that cannot speak up for themselves. Okay, the next thing I want to hit on a little bit, we kind of talked about it again, aggression versus anger. And basically, these are the definitions here. Or so basically, with anger, these clients, they're unrestrained. They're unrestrained could result in things like harmful physical, emotional effects. Blood pressure can go up, headaches. They can have insomnia because they can get so upset, angry. Could have some digestive issues like diarrhea. They can be constipated. They also may be a possibility that they want to harm themselves or others. So these clients also need to be on suicidal watch. They may start cursing, be sarcastic, yelling, breaking an inanimate object, or making a fist, you know, most oftentimes followed by an act of aggression. So these are the clients that can be very violent. They can help hurt themselves or others. And you see this in certain cases, clients with schizophrenia, autism, ADHD, they are found to have higher serum level of serotonin in the blood. So again, so these clients would need to be on some medicine to help decrease that serotonin level. Okay, so as we talk about anger versus aggression, we talked about this little wheel last week. In the center, you see exertion and power and control. So again, we talked about using coercion, threats, using intimidations to threaten somebody, emotional abusing someone. Also using isolation. Don't want the individual to go around anybody. They just want them to be isolated. Then denying and minimizing, blaming. So they shift the responsibilities on toward the abuser. I mean, to of the abused one to the others. Like if I'm the abuser, then I'm going to shift the responsibilities over, or blame that the individual. If you didn't do this, you know, I wouldn't have done that. So they are very demanding, very controlling type of behavior among the abusers. And then using children, I would have left, but I don't want to leave because of my children. So they stay there and they take the abuse as a result. Using privileges, they don't allow the individual to make decisions. They feel like they don't have equal participation in relationships. And then, like I said, again, using the exploitation of resources. Again, if they, for instance, if the victim is working, the abuser may not allow them to work, or they may, if they do work, they may want to control the finances. And then as far as risk factors, you may see a person that will be like an abuser. They would have usually have a history. They've seen this maybe in their environment. They've grown up in the environment as such. They may also have mental health issues. They may be a victim of a crime, witnessing abuse of a crime, or they could have poor self-esteem themselves, inadequate coping skills, and then again they may not have had any positive role models throughout childhood. And then again, they may also have experienced some adverse childhood experiences as a child. So again, that's why it's so important. We go back, we do an assessment, want to know has anything going on in that child's childhood that would make them become abusive, uh, or would they stay in a relationship because they've been abused as a child themselves. So as far as etiology, it could be genetic in nature. It could be social determinants, again, cultural, economic issues, could be political motivated, or it could be related to some medical condition. Things like damaging to certain parts of the brain. Also, Alzheimer's disease, and then addictive personalities also. Again, so we'll have to look at the etiology, and this is where your assessment is going to come in, collecting data, trying to determine. So these are some clinical manifestations of a perpetrator. They use defense mechanisms to shield one from disagreeable or objectable thoughts and sensation. Again, they displacement can where the client may be angry with a coworker, but guess what? They express that anger toward their partner, their child. So this is displacement. They're displacing their feeling on someone else because somebody else has made them upset or angry. And undoing. This is where the client emotionally abused their partner in front of others, but the next day they may buy them a gift or something, uh, because they're trying to undo what they have done. Okay? So this is a lot of time when people stay in a relationship because they don't want to leave for certain reasons. Well, he's not going to do it anymore. She's not going to do it anymore. Things of that sort. Then violence, of course, is basically its ultimate a form of aggression, such as murder, rape, and physical assault. You see increased risk for violence among the individuals, like again, those just use substance abuse, people that with TBIs also, TBIs, PSD, those kinds with bipolar disorders, impulsive control disorders, attention deficit. Then again, exposed to violent situation, going back to the adverse childhood events. So anytime somebody gets frustrated, they may misperceive others, that it could lead to violence as well. Okay, so some warning signs of in an inpatient setting, a client may the nurse needs to recognize warning signs to protect themselves and others from violent outbursts. So again, things like a client may decline to eat or drink. They may attempt to leave the area before discharge. They may sign out AMA, or they may be a verbally antagonistic toward other staff or visitors. They also may harm themselves. They start staring. They may be pacing. They may just start destroying inanimate objects. So we need to recognize those signs, and then again make sure that when you're dealing with clients that shows these signs of frustration, we definitely need when you deal with these clients from a team approach. We don't ever try to handle a situation ourselves. We always want a team. Like I said, a team approach. Perpetrators and victim behavior. As you can see, this is a chart that compares the two. A perpetrator usually develop an unexcused or rationalized behavior, whereas the victim blames themselves as a reason for the abuser. So if I had cooked on time, he or she wouldn't have done this. Non-communicating, no attempt to cooperatively develop a solution. So then the victim feel like there's really no solution to the behavior, there's nothing I could have done. And then the perpetrator usually, like I said, the intimidation to control others as a means of temporarily resolving unwanted feelings of emotion. So the victim do not feel like financial emotional independence is possible. So again, they stay there because of that. And then the perpetrator may use sex as a method to relieve unwanted thoughts or feelings, pornography. So again, they're trying to. This is a way of coping, I would say, that they think would be acceptable as a perpetrator. Then the victim has lack of desire to engage in sexual behavior and reports setting poor boundaries of sexual engagement with others. So they may just, okay, I'm just gonna go and just have sex because I have no control. I've been so abused. So guess what? This is something that they just have poor boundaries when it comes to sex, and particularly engaging with others. Okay. Then childhood. We talked a lot about childhood. That again, particularly, specifically, we need to know anything that had gone on in a childhood, in a child's during childhood that could exacerbate or could indicate or cause these children to be abused. So again, these are potential traumatic events that a child is before the age of 18 could affect them later on in life, both emotionally and physical. So those clients that have had adverse events, they could experience violence, like I said, neglect. They also family members could have attempted or died from suicidal. They could observe abuse in the home. They could have been in an unsafe and unstable environment. Again, so those children that have they are more likely to engage in violence, substance use, criminal activity as they get older. Therefore, they mirror the behavior in which they was growing up in, they've grown up in, they witnessed as a child, and then they become the aggressor. They feel like it's okay because it went on in our home and it was acceptable in the home, so they feel like it's okay. And then abuse and neglect, we kind of talked about that. We are mandatory reporters. Again, child abuse prevention and treatment program um, was an act that was passed, again, which requires us to report. And the act talks about parent or caregiver that result in death, could be serious abuse, physical, emotional, sex, exploitation. So again, anything that causes an imminent effect or serious problems with an individual is we have to report it. So we have to educate. Like I said, the majority of the state and all states have processes in place, but I do know Alabama. So whatever state that you're working in, you need to know what the law says about reporting um, abuse and neglect. And then we see a lot of times children they are usually abandoned. They're found um, you see this in all ages. Elderly adults also they are abandoned. Also, these are serious abandonment. Also, is a serious offense. You know, leaving someone alone that cannot take care of themselves, and I've seen a lot of elderly people being abandoned because they have no one to take care of them, but somebody's getting their check. So anytime you see this, we have to report it. And I used to tell the nurses all the time when we did home health, if they go into the home if they get there and there's a family member there, and by the time they get ready to leave, the family member's gone, you got a bed-bound patient. The family member has left. Guess what? That nurse couldn't leave. They had to get somebody there before they could leave because otherwise they will be responsible for leaving that client home alone. Bullying, we talked about that a lot, and I'm not going to read that verbatim. So again, we disencourage bullying. We again, some of the schools have what we call anonymous apps, so students that are being bullied, they can report it anonymously. Bullying can lead to suicidal, homicidal, and suicidal. So again, we need to really reiterate that. And bullying can come in many forms, not just talking, not just hitting, but also name calling, just targeting someone, destroying someone's property. Okay? So we need to really talk about that more often. And again, like I said, a lot of things, initiatives are being placed in schools regarding bullying. And some of y'all gave me some examples on how you all were bullied and what you did to defend yourself on last week. The next thing I want to talk about is intimate partner violence on the teens and adults. Again, physical abuse comes under that. Stalking, psychological aggression falls under intimate partner violence, and it does not require sexual intimacy either. And it's more common in women than in men in the United States. And also, you see a high risk among your LGBTQ communities. And there are three phases of intimate violent phase. First, that phase one, this is where that phase can it's called the build up phase. And in the build up phase, what usually happens, it can last anywhere from days to weeks, years. This is where breakdown in communication starts. Perpetrator initiates more arguments. Then the environment becomes more tense, and then abusive incidents start to begin. Um, so again, in this phase, again, survivors may develop medical issues. They may, in this build-up phase, they may have been under so much stress they cannot reproduce. Their reproductive system has been altered. They may have some cardiac problems, may have some skeletal muscle problems. So they are more likely to participate in behavior detrimental to their health, such as unprotected sex, smoking, excessive consumption of alcohol. So all this starts in phase one, which is the build-up phase. Then in phase two, it's the acute battering phase. It's normally limited to a few hours, up to 24 hours. Abusive acts are filled with rage and intensity. And then a law enforcement may become involved during the acute battering phase. Again, it also can cause or create other healthcare issues as well. And then you have the honeymoon, the reconciliation phase. That's where the perpetrator becomes very affectionate, apologetic toward the survivor. They have regretful action and promise to change. And they will frequently continue to maintain control over their survivor through economic and emotional abuse. Again, like I said, this is where the partner may not work, so they're totally dependent on the spouse to take care of them. So this is the honeymoon phase, and then this is also then they try to reconcile. They buy gifts also in this phase, trying to they send them some roses and things like that. But this is the phase right here when they get to that acute battering phase, and it, like I said, it's escalated. If the behavior doesn't change, there's no reconciliation, then the abuser the victims usually end up leaving. So if that is the case, when they decide to leave, they need to leave because if they go back, it could get worse. Somebody could get hurt. So this is the time we talk to the victim about getting prepared, have an exit plan. So if the spouse comes home and just and attack the wife or attack the children, and when they get really fed up, they'll attempt to leave, but they need to have a plan in place. And in that plan, they need to have where they're going. They need to have like a bag, like a backpack with personal items, and they can't take everything on one trip. So they need their any contact information. They need insurance. They need the schools. If they have children, they need immunization records. They need health insurance records. They need medication, and also they need a plan. So say the perpetrator may come in and pull a knife out. So you want to have a plan. Okay, we're gonna exit. Everybody gonna exit out of the back door at one time, or whatever the case. You may want to let the neighbors know what's going on so they can kind of listen out and call the police if they hear any noise. So they need an exit plan. They need to have again. Sometimes they can go to like the shelters or something like that until they can get help. But most importantly, like I said, they need to have a plan because once they leave and they go back, they may end up being seriously injured, or the child or children may be injured. Elder abuse again, same thing. You're going to see neglect, exploitation, abuse. Uh, Again, these individuals they usually depended on others for care. They, with that being said, they also can have some cognitive impairment, physical disabilities, and again, in those with few friends and family members. So sometimes elderly abuse go unnoticed more so than child abuse because elderly are more confined to the homes for the most part. But children, they go kind of go out to school, and someone like a young adult or mid adult, they out at work, so you can kind of sense those behaviors or something like that. But the abused person, they usually they are kind of confined to the home, so they really depend on someone else to help them out. So with that being said, we have to report elder abuse just as we would child abuse. Rape and sexual assault. This is basically where they force themselves to someone to have sexual intercourse, which also includes both physiological coercion as well as physical force. Um, and then we talk about a sexual assault or rape. Forced sexual intercourse involves penetration by the offender. So now, two-thirds of victims know that they're assailant. That usually they know who their assailants are. They know their acquaintance. So sometimes these individuals, they are raped, being that they know their acquaintance, that their acquaintance may kill them because they know that they can recognize them. So very seldom do they can actually walk away alive, because of the fact they know who's assaulted them. Statutory rape is defined as an adult having sex with individuals younger than the age of 18 years of age, even if the minor consents to sex. I know some states this could vary, but based on the national norm, the age is 16. That means, I'm sorry, 18, that regardless of the fact they if they consent, they are not of age to consent, so it's considered statutory rape. And then again, sexual assault involves unwanted sex contact between survivor and an offender. It can be verbal threats, it could be fondling, it also could be grabbing. So again, we can't just touch people. So like I said, prior to that exemption allowing married couples to have non-consensual sex with their partner without worrying about legal concern. But within the last 30 years, the law has been changed, enacted in all states against marriage or rape. If you're married to someone, they still cannot rape you. So they can be charged just as well. So the law changed about 30 years ago. Prior to then, it wasn't considered a criminal offense, but now it is. Although you're married, you still can't just force sexual contacts on anybody or rape them. Stalking basically is unwanted attention, threatening, harassment, things like that. Again, it's usually involved individuals known to the person being stalked, for the most part. Sorry about that. I was trying to get some issues resolved with this laptop. But anyway, so stalking um, could be like following or watching someone, sitting outside their homes, getting a target their cars, watching them as they leave work, showing up on unannounced visit, workplace or school, nuisance phone calls, and text messages, etc. Um, so that's stalking. And then care for survivors. Again, survivors may say deny that anything has happened, even in a rape case or neglect or whatever. So, in the event of suspected abuse by a person, competent decline, the interview should take place away from other people. If they present to you when you want to talk to them, like they may come in an ED or a doctor's office. So again, all people at the interview should introduce themselves and explain their role. So usually what happens when a rape victim come in or abuse victim come in or whatever the case may be, the interview is done in private. Because the survivor could be very fearful what would happen to them once they leave the facility. So usually if the perpetrator comes with them, they are very discreet. They're not going to talk a lot. So we got to be very wary of the healthcare professional that we have on the team. Usually social workers are going to be involved, and then counselors and things like that. So these clients may be sleep deprived, or they may be malnourished. So my point is this: when the survivor, they do come to the emergency department, we need to get them. If they've been raped or been abused, we don't want to let them sit out in the waiting room. We want to get them back. We want to interview them in a private area. And then sometimes the perpetrator do not want to leave. So if they want to do not want to leave, what we can say, okay, what we need you to do is we need to do a private exam on the individual and ask them to leave. And sometimes they still don't want to leave. So we this is where you may have to get security involved because the interview needs to be private because if somebody's been abused, they're not going to talk about it in front of the perpetrator. So interview techniques, physical location of the interview, who will be present, like I said early on. The approach should be gradual, non-threatening, conversational. Let that person tell you what happened. Do not touch the survivor without asking permission to do so, because again, if they've been threatened, they've been abused, touching them may, they may feel threatened again and they may have, they feel that they've been traumatized. So again, always asking, can I, before you, oh, I'm so sorry, patting someone on the shoulder, you want to get permission to do so. Traumatic effects may be exhibit during the interview and should be treated respectfully. The client may say, "Well, I just lost. I was not hit in the head. I don't remember what happened." They can become emotionally reactive. They can tell several versions of the story because they are trying to tell it. So we want to give them. So in the event of possible suspected abuse by a person accompanying the client, like I said, it should be taken away from that. You don't want to interview in front of that person. So all the people at the interview should, like I said, tell who they are and their role, so that the victim will know that everybody's here to help them. Okay. And so as far as the role of the nurse, we have to make sure we give equitable and sensitive care, be self-aware of client's feeling. The care is self-centered. We need to look at management of agitation. They get agitated. We have to get them something to kind of calm them down. And we need to also talk about some preventative measures. If you go back to the home, this may be something that going to be a reoccurring, and you could really be harmed for the most part. So as for self-awareness, we have to be unconsciously discriminatory attitudes could trigger some negative reaction of fear. Also, we have to make sure that everybody is created equally, regardless of their religion, their ethnic background, and we can't stereotype either. So we got to be careful, conscientious of that. Habit breaking strategies we want to recognize. Again, we want to practice making sure that everybody get the same providing the same desired outcomes. Practice the best desired behaviors rather, so we can get the best outcomes. What I'm trying to say. So we're gonna be focused on the present. Take deep breaths. Slow down. When you enter the room, like don't become like, oh, I'm sorry, paying attention to others' feeling and to be. Or sometimes when clients come in, they've been raped, you don't ever want to say, well, why did you go? Why were you drinking? Da 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 da. We don't want to be judgmental. We have to provide that care that is client centered. We want to develop that relationship again based on the client's culture. Also, again, being aggression can signify, if that client is aggressive, it could mean that they are very stressed, they are scared, and their needs have not been met. So again, conscious of those clients' feeling. Managing and agitation, like I said, we want to remove the client from what may be annoying them. So it could be the staff or another client. So again, this is why I want to get them in a private area for the most part. Again, don't have them sitting in the waiting room because it could cause some more aggression as well. Allow those agitated clients some space and time to regain their calm demeanor. Ask, what can you do? Respond in a calm manner. Don't yell. Don't show any anger toward these clients. Don't speak in any anger tone, which could escalate the situation. Situational awareness. Do not stand directly in front of the client or within arm reach of the client, because again, if they're agitated, they may start swinging. So avoid having the client feel that they are trapped or blocked by the doorway, because you don't want to block them in. Um, then again, you need to know the layout of the area and how to remove yourself if necessary. If you're in a situation providing care, because if they get agitated, you want to exit as soon as you can. Also, managing agitation, again, like I said, you want to no, I'm sorry. Uh, Again, make sure you have enough help and don't get trapped in it yourself in a situation. Community violence, safety first. Protect oneself, from doing an active shooter events. Now, we've seen a lot of active shootings in the schools. So the run model, hide, fight, is recommended for all individuals experiencing active shooters. So you want to safeties, you want to escape or get, if possible, you want to hide if you can't escape, and then you want to fight as the last result. So again, safety is going to be the first thing. Triage, you're gonna, if somebody's, if you are um in a community where there's violence, when the area becomes safe, that you can provide nursing care. You want to triage, control bleeding, prevent any further injury. Then, of course, airway and hypothermia. But again, as a last result, you want to try to disable the intruder, preferably with others, not alone. You're going to try to take them down, because if you can't get out of the way, they could hurt you. So again, then after that, you're going to start triaging those victims if possible. Um, this is also, I have some more slides in here on the forensic nurse, but basically, I don't know where that R got kicked off there, but forensic nurses basically it's a registered or advanced practice nurse who have received additional education specific for violence or victimization. They work with survivors of sexual assault or sex survivors of intimate partner violence, child mistreatment, abuse, older adults, and death investigation is the forensic nurse. Again, they have received additional training and certification to be a forensic nurse. They may work in correctional facilities, assist with investigation following mass casualties, events, or disaster. And also, you may hear the term same sexual assault nurse or forensic nurse. Sometimes those terms are used interchangeably. So these forensic nurses also, like I said, they can do sexual assault kits. And then again, that sexual assault nurse can do them as well. But they have to have training beyond the basic. Again, like I said, you may hear the term sexual assault nurse or SANE nurse, and that's their role. And then the next slide talks about the SANE nurse. It's a registered nurse who again have advanced training in forensic examination. In some communities referred to as the forensic nurse examiner. So those terms, like I said, are used interchangeably. So what they do, they conduct focused genital exams. They do the rape kits, preserve specimens to collect evidence. They debrief potentially traumatizing situations. They can also administer medicine to prevent STIs when those clients have been sexually assaulted, and they may be an expert doing a legal proceeding. So the big thing here for those sexual assault or forensic nurses, collecting that evidence and making sure that it's not tampered with. Making sure you follow the chain of custody when you collect it. It's going to be secured, and whoever you give that kit to, it can't. If somebody presenting a kit to you, say you're the supervisor, the kit been done. So actually, that kit has to have a chain of custody. You sign off that you're giving it over to Miss Jones. Miss Jones signed it over. So again, there has to be some consistency there with that chain of custody form. And if there's any break in evidence, a lot of cases have got thrown out of court because there was a contamination of evidence. So preserving that evidence and making sure that it get to the right people is going to be very critically important. Okay, so I just want to share that with you. And this is why they are stopped. We used to do them a lot in the ED. So you have to be specifically trained to do those. We have certification to be a sexual assault nurse. So as we look at the nursing process, we have to, when we're doing our assessment, we're going to be recognizing cues, analyzing those cues, and prioritizing the hypotheses. Generate what are we going to do about it? We're going to take action. I mean, not take action. Develop your plan of care, generate solution. Then we're going to take action. Then we're going to evaluate. So again, these are some signs that we can that could be recognized as a part of your recognizing cues, awareness that could help the nurse to prevent abusive aggression, violence outbursts. So this awareness by the nurse helps to predict potential violence, allowing the nurse to intervene as needed. So if somebody's obvious, you see them the clenched fist, raising tone of voice, or avoiding eye contact, pacing intense and being very tensed up, could be some cues that you want to put up as a part of your assessment. History, you want to get a good history, any previous occurrence of violence, abuse, or neglect. This includes clients who have been exposed to abuse and aggressive behaviors, age and gender of their client. Like I said, older adults are likely to engage in violence. Women are less likely to do so. Socioeconomic status, we're going to look at that. Is the client coming in? Are they, their needs have not been met? They have dinner carries. They have not gotten their prescription filled. So these are all cues that you want to hone in on. Look at stress. Have they lost their job? Have gone through a divorce? These things that could trigger also unemployment within the past year. And then also we're going to analyze those cues. Look at those, link those clues to powerful causes. Active listening, establishing therapeutic relationship is instrumental in establishing trust with your clients, allowing the nurse to provide evidence-based care. Okay, safety and preventing harm to self and others is a priority. Again, therapeutic environment is essential. Client needs to feel safe. Okay. Alrighty, so that's what we're going to analyze those cues and prioritize. Then we're going to generate solutions. We're going to, with the clients experience anger and aggression, abusive tendencies, also violence, we need to examine which of the following strategies is to employ. Do we de-escalate? Verbal de-escalation should be used first if possible. Try to talk them down, okay? And then if not, we may have to go to medication, pharmaceuticals. Then if pharmaceuticals doesn't help, we go to restraints and seclusion. Okay? So again, know your restraint policy, know your seclusion policy. Again, you must have to have physician orders to restrain. And if you need someone else, more than one person, you need more than one person to help with the restraints. Okay? So de-escalation, pharmaceuticals, and then restraints and solution. Then we're going to take action. These are some non-pharmacological measures we can do. So again, physical activity, boredom leads to aggressive acts, okay? So we need a contingency plan. So we're going to reward these clients for desired behaviors. And then we can, like I said, it's limited the treatment of self-injury or violence. They may have to be in seclusion for that. And then physical restraints. When we put somebody in physical restraints, we want to make sure that they they can move their head, their trunks, and their extremities. We don't want to just restrain them where they can't move anything. Okay, so now chemicals. These are some medications that you can use to chemically sedate these clients. But again, make sure that you have a physician orders. So utilize restraint and seclusion should be minimally implemented by qualified care providers only when necessary, ensuring that current standards of practice are always followed. Always remember, an important concept to keep in mind is that the least restrictive method for behavior control should be used first. Okay? Seclusion, placing the client by themselves in a room area which they are physically prevented from leaving. Clients may, on occasion, may recognize a need to be secluded. They can ask for time out by stating, I need a break. Clients are able to leave the time out when they choose. So again, they can ask to be in seclusion. Again, de-escalation, respect their personal space, remain calm. You want to engage, establish verbal contact, introduce yourself, say the client's name. I may need to be repeated, okay? Simple smile and be concise. Keep direction, questions simple. Wait for the client to respond. You want to also identify wants and feelings. You're going to use reflection to help the clients feel like let them know that you understand what they're saying. So you can reflect the reflection questions, okay? Set clear limits. You want to set clear limits. Make sure that the client understands what is acceptable and what is unacceptable. You want to also give the client an option. Offer choices and optimism. Let them decide what food, water, space, or blanket they do, as long as it's nothing that could hurt them. Okay? So again, kind of talked about that, about seclusion and restraints. We don't use seclusion or restraint to penalize somebody. It's not a punitive measure or coerce someone. Okay? Like I said earlier, restraints requires prescription. 5 staffs are used to apply the restraints, 1 for each extremity, 1 for the head. Okay? They're placed in supine position, one arm extended above the head and the other at their side. We want to make sure that those restraints are not impeding circulation or causing any pain. Prescription must be include the reason when you get the prescription, the orders. You must include the reason for the seclusion of the restraint, the length of time, the type of restraints, and the criteria that's going to be needed for removal from seclusion of restraint. The clients are evaluated, reevaluated by the provider, the RN, or the physician assistant within 1 hour. You got to go back and reevaluate those clients, evaluate them. Restrained clients are not to be left alone. We need to make sure we observe any injuries, breathing, or any physical difficulty. And again, make sure that the client needs are met. If you know if you got a restraint, they can't go to the bathroom, they can't feed themselves. So we got to make sure we consider that. Again, those clients that are in seclusion or restraint, they must be assessed by the RN hourly. That include a physical and a mental status assessment, vital signs, pulse oximetry, assessing the circulatory status and skin integrity. If restraints have been applied, the range of motion exercises executed every 2 hours. So you got to, again, help them move those extremities. All interaction with the client should encourage behavior that will promote release from restraint. Let them know, okay, when you calm down, when you stop fighting, or whatever the case may be, then we'll look at removing the restraint. So constant communication is critical, and observation is critical for these clients. The criteria for releasing, again, client meets the behavior criteria established at the onset and assessed by the approved provider. All viewpoints, description of the episodes involving seclusion restraint are to be documented. Document everything that led to the client be very specific, what the client did. Clearly, everything has to be documented. Okay? These are some long-term action, some things that when we take an action here, some pharmacological medication, long-term control of aggression could be your antipsychotic meds, your mood stabilizers, some anticonvulsant, also antidepressant. So for clients having been physically restrained, administering those sedating medication, such as lorazepam or haloperidol, is common. So those are the common ones. If they really, really been very agitated or they become very aggressive. So most common ones going to be your lorazepam and your haloperidol. So again, even if they get these medication, the healthcare provider should use the smallest dose possible to achieve the desired outcome quickly, but not cause any harm. So you want to start at a lower dose, and then we may have to go up to a higher dose. When oral meds fail, it is common to administer IM injection. Now, usually if they're really really agitated, they're not going to swallow anything, so we may have to go straight to the IM injection. So a medication that usually prescribed by the psychiatrist, it's in combination like a 50 milligram of diphenhydramine, diphenhydramine, 50 milligrams, haloperidol, usually 5 milligrams, and 2 milligrams of lorazepam. Like I said, usually we have to go straight to the IM because they usually won't take pill medication if they're highly agitated. And then these are some other medication, including olanzapine, your PAM drugs, also LAMs and PAMs, and also chlorpromazine may be used, promethazine may be used, ziprasidone also. These are some common ones that may also be used. So again, we start with the lowest dose. Try to, if the pill is not tolerated, like I said, we usually have to go to IM. And I've seen IM more commonly used because if they really, really agitate, they're not going to swallow anything. They're not going to follow orders either. So again, debriefing, this is part of your evaluation, your outcomes. You want to discuss any of the perceptions from the client, support the client, get them to return back to the unit, milieu unit. Look at different approaches that we can use with these clients rather than sedation or seclusion or restraints. Listen to the client's point of view. Provide guidance to the clients because they do believe that their rights have been violated. So again, although they've been institutionalized, they still have rights. And also, we need to adapt the plan as well, as needed. Non-suicidal interventions here. Uh, we need to help these clients with coping mechanisms. Clients engaged in NSHH do so. Uh, they do it to cope with emotional pain. Some clients say that they allow them to feel comfortable. Again, some intentional. These are intentional harm of self involved. They may intentionally. They are deal non-suicidal. They don't want to hurt themselves, but they are trying to get attention. So they may cut themselves, they may scratch themselves, they may be biting, uh, um, carving words or design into their skin, burning themselves, pulling their hair, head banging, and then again. But they don't really these are non-suicidal, but they don't really want to help themselves. I mean, hurt themselves to the point where they could, they're not really trying to kill themselves. They're just trying to get attention. Is basically what I'm saying. Some risk factors could also be some adverse childhood events, poverty, abuse. Usually start in adolescents usually in school due to school pressure, unhappiness, and then again eating disorders, borderline personality, and substance abuse disorder could be some risk factors of non-suicidal. Some warning signs again: unexplained scars, cuts, burns, scratches, bruises that cannot be explained, rubbing the skin that leads to burn. I think keeping sharp objects available but hidden, keeping their arms and legs covered up, even though it's hot, they may have on a long sleeve just to disguise their injuries. Poor interpersonal relationships, poor identity issues, and unpredictable impulsive behaviors. Okay. So these are some long-term effects of non-suicidal. Could be infection as a result of the cuts or the scratches or burns, scarring, excessive bleeding, shame and guilt, reduce a sense of self, social isolation, and then again, studies have shown that NSH is one of the most dependable forecasters of a future suicidal attempt and should be taken very seriously. Um, some interventions that we can put in place could be reaching out immediately, uh, getting help to these clients, so that develop a trust relationship with them. Explore creative avenues like things where they can start coloring, drawing, writing a journal, or exercise. Trying to get them to explore things that's causing them to be distressful and making them feel like they're not worthy. So we can try to get the appropriate referral then, suicidal hotlines and things of that sort. So we want to intervene as soon as possible when we recognize those signs and symptoms, and then develop a plan that could be implemented when they feel like they want to engage in suicidal attempts. Educate the client. And then again, like I said, establish a support system of trusted individuals, and this is where you may see where again somebody they can trust. They may be referred to so, a peer that they can really trust, or maybe like I said, there's hotlines. There are all sorts of resources that we can link the client to make sure. So basically, that is all. I wanted to finish up that lecture, and I kind of went back to the beginning. So I hope you all enjoy, but I will upload it to the